Hello guys, we'll study ventricular septal defect. It is a defect in any part of the ventricular septum and it is very common of all CHDs. There are four kinds of ventricular septal defect. Perimembranous, involves the membranous part of the septum, muscular, and it could be inlet or subpulmonic, which is rare. There are four types: subpulmonic, inlet, muscular, and perimembranous. What is the pathophysiology? Left to right shunt of oxygenated blood. The blood from left will go to right, and there will be increased pulmonary blood flow, so increased pulmonary hypertension. And as age advances, there will be structural changes in pulmonary artery, and irreversible pulmonary hypertension will be there, and Eisenmenger syndrome will be there. So, due to high pressure gradient between LV and RV in VSD, most blood shunts directly into pulmonary artery, and PA, LA, and LV enlarge first. After birth, pulmonary vascular resistance is naturally high and takes 6 to 8 weeks to regress. So hence in moderate to large VSD, shunt flow becomes significant after 6 to 8 weeks. CHF and most clinical features appear after 6 to 8 weeks. So a small VSD is restrictive, hence left to right shunt does not depend on PVR flow. Across shunt is not significant. What are the clinical features? Depends upon the size of the VSD. If the VSD is small, it will be asymptomatic and there will be a trivial risk of endocarditis and there will be murmur which can be detected at 1 to 6 weeks. So if the VSD is small, no symptoms, risk of endocarditis, murmurs heard at 1 to 6 weeks. Moderate to large VSDs, there will be symptoms. What will be the symptoms? Feeding difficulty, suck, rest, suck cycle. First sign. A normal infant sucks at mother's breast for 15 to 20 minutes and then sleeps for about 2 hours. In infants with L2R shunts, the infant can suck weakly at breast for about 5 to 10 minutes, after which it sleeps for only half an hour and wakes up again hungry and the cycle repeats. This is called as suck, rest, suck cycle. Recurrent respiratory tract infections, congestive heart failure, that means breathlessness, feeding difficulty, sweating or over forehead, failure to gain weight due to feeding problems and recurrent infections. So what are the symptoms that will take place? Feeding difficulty, suck, rest, suck cycle, respiratory distress, congestive heart failure, breathlessness, feeding difficulty. And sweating over forehead. What will be the signs? There will be failure to gain weight. There will also be failure to gain weight. Then there will be tachypnea, congestive heart failure, increased precordial activity, cardiomegaly, hyperkinetic precordium with thrill at left sternal border, and murmur. What all things you'll see? You'll see murmur, precordial precordium is hyperkinetic with a thrill at left sternal border, increased precordial activity by 4 to 6 weeks, cardiomegaly, and congestive heart failure, that means tachypnea, tachycardia, dependent edema, hepatomegaly, raised JVP, and then tachypnea. Happy tachypnea appears comfortable in contrast to ill of respiratory causes of tachypnea. There will be happy tachypnea, precordial activity will increase. The precordium will have hyperkinetic, cardiomegaly, murmur will be there. Side left lower parasternal border, pansystolic. Intensity small VSD, loud grade 4 to 5, large VSD, soft grade 2 to 3. So if the VSD is small, the murmur will be loud 5 to 6 grade. If the VSD is large, the murmur will be small 2 to 3 grade. Mechanism: left ventricle starts contracting before right ventricle and shunt flows continues throughout systole. So S1 and S2 may be masked. Duration: decurrence endo may disappear in later third phase of systole. Quality: small VSD harsh, large VSD soft. Transmission: localized in small VSD, transmitted in large VSD. It is localized in small VSD and transmitted in large VSD. Additional murmur: mid diastolic murmur in mitral area. Large VSD, sign of pulmonary hypertension may be present. Loud P2. Widely split S2 A2 becomes before P2 asked by murmur. In PDA, there will be no P2 sound even when there is pulmonary hypertension. But here there will be widely split S2 A2 becomes S2 and A2 becomes more comes before P2 and masked by murmur. Thus, S2 is split, P2 is widely, loudly heard. There will be murmur. There is hyperkinetic precordium. There is cardiomegaly. There is increased precordial activity. There is congestive heart failure, and there will be tachypnea. Remember the signs: heart failure, tachypnea, congestive heart precordium is hyperkinetic. There will be wide S2. P2 will be heard loudly in murmur. If the shunt VSD is large, how sound will be small, soft, and if it is small, sound will be large. And it is continuous. It is pansystolic. It is heard in the left lower parasternal border. In PDA, it is heard in second intercostal space on the left side. It is here. It is heard in left lower parasternal border, right ventricular area. What are the investigations in ECG? You will see left axis deviation and left ventricular enlargement. And then in CXR, you'll see LV enlargement, cardiomegaly, pulmonary purpura, dilated pulmonary trunk, and in echo is confirmatory. So in ECG, what all changes you'll see? You'll see left axis deviation and left ventricular enlargement. And in CXR, you'll see LV and enlargement, cardiomegaly, cardiopulmonary plethora, and all that. So now let us see. Okay, what are the investigations? So natural history and management. In medical management, you'll do you'll maintain nutrition. You'll have to give adequate calories. You'll have to prevent anemia. You'll have to treat respiratory infections. You'll have to for infection prevention, you'll have to give immunization of HIV, streptococcus pneumoniae whenever possible. Treatment of congestive heart failure, diuretics, digoxin, AC inhibitors, and inotropes. So what is the medical management of VSD? In medical management, you'll have to give proper nutrition. You'll have to prevent anemia. You'll have to treat any infections. For prevention of infections, you'll have to give vaccines of HIV and then streptococcus whenever possible. And for CHF, you'll have to give CCF. You'll have to give digoxin and AC inhibitors and inotropes and diuretics. Indications for surgical closure. For surgical closure, there has to be moderate to large VSD with uncontrolled CHF, recurrent respiratory infection, and growth failure. So if there is recurrent respiratory failure, infection, growth failure, only then you will do surgical closure. In older children, if there is a left to right shunt more than 2:1, small VSD with infective carditis, even if the VSD is small but there is infective carditis, then you saw that in small VSD they are asymptomatic, but they have a small risk of endocarditis. And there was another feature that I don't remember right now, which was murmur will be there. And if that is there, then you'll have to do USG with aortic valve prolapse. Contraindicated after development of Eisenmenger syndrome, you don't have to do any surgery. Large VSDs, refractory CHF, and severe FFT close as early as possible, 3 to 6 months. Moderate VSDs with PH, 1 to 2 months. If there is severe FTT, then do it in 3 to 6 months. If it is moderate, then 1 to 2 years. Mode of closure: open surgical patch closure, device closure, and pulmonary artery binding for large VSD with PAH. So you'll have to do device closure, pulmonary artery binding, and open patch closure. What are the complications of VSD? You will have congestive heart failure, growth failure, infective endocarditis, Eisenmenger syndrome, sudden improvement in clinical signs symptoms, no recurrent infections, decreased requirement of anti-failure medication, cyanosis, clubbing, parasternal heave, appearance of early diastolic murmur of pulmonary and pansystolic murmur of TR, tricuspid regurgitation, single loud and palpable P2. Outcome: result of surgical repair is excellent. Residual lesions and long-term applications are rare.